Hi there, everyone. Welcome to those of you who are joining us already. I'm just going to give it 2 minutes for folks to trickle in, and then we'll get started. Okay, hi, everyone. I'm going to jump in and get started. Welcome and happy International Development Week. My name's Emily Antze, and we're so thrilled you're able to join us today. This panel will run for about 1 hour, and the format will be a discussion with our two esteemed panelists for about 35 minutes, and then we will have a question and answer period towards the end. If you'd like to ask a question, please submit it through the Q&A function on the webinar, and we'll get to as many as we can. So I want to start out by just introducing Partners in Health for those of you who don't know us. So Partners in Health is a global health and social justice organization with the mandate to deliver high quality healthcare for those who need it most. When we say those who need it most at Partners in Health, we're often referring to people living in places in the world where there's extremely high levels of poverty. Because from our experience and epidemiologically, people living in poverty are sicker. So we think they're more deserving of high quality health services that address the burden of disease. At PIH, we accompany governments and communities to build public sector health systems and provide social supports that can meet the burden of disease wherever we work, which is currently in 11 countries around the world. We have a long way to go, but initiatives like the one we'll be talking about today can have a really genuinely transformative impact. So we're here today to showcase some of the results from the No Woman or Girl Left Behind project, which has been working in Malawi and Sierra Leone. It launched in 2019 and it just concluded at the end of November. The project activities of this project integrated key pillars of Canada's feminist international assistance policy, including interventions aimed at reducing maternal mortality, the prevention and treatment of gender-based violence, and the introduction of adolescent and youth-friendly health services accompanied by school outreach, community engagement, education, empowerment, and so much more. We're deeply grateful to Global Affairs Canada and to the Slate Family Foundation for their wonderful support of this work. And for myself, I am a senior program manager at Partners in Health Canada, and I've had the good fortune to be the grant manager on this project since it launched in 2019, doing the reporting and having chances to be on calls with my colleagues in Sierra Leone and Malawi every week, just learning about how the project's going, how the work is going, the challenges they face, and the really remarkable results that they've achieved over these 6 years. So there's a lot we're really proud of and excited to share today. And we're so grateful for the participation of our two incredible panelists, my colleagues who have both been integrally involved in the project implementation and supervision from the very start of work in 2019 until today. So I'm going to ask our panelists to come on camera now. And I will introduce them. So first, I'm going to introduce Basimenye Nhlema, who we also call Sime. So if you hear me addressing her as Sime, that's Basimenye. And Sime is the executive director of PIH's Malawian sister organization, Abwenzi Paza Umoyo, or we call it APSU. She's responsible for spearheading a partnership with the Malawian government through the Ministry of Health with the aim of strengthening the provision of essential health services in Neno district and in Malawi at large. Before she transitioned into this role, Sime was PIH Malawi's chief operating officer for 2 years. And before that, she was the director of community health. So when the No Woman or Girl Left Behind project initially launched in 2019, she was in this director of community health role and was directly overseeing the community-based activities associated with the project and planning and program design at that stage. Sime holds a Bachelor of Arts in Humanities degree in Drama and Public Administration from the University of Malawi and a Master's of Arts degree in Dramatic Arts from Witwatersrand University in South Africa. And then our other panelist is Isata Dumbuya. Isata is the Director of Reproductive, Maternal, and Newborn Child Health for PIH Sierra Leone. She's a registered adult nurse, a registered midwife, a specialist public health nurse for children aged 0 to 19, a Global Nurse Executive Fellow, and a Woman in Global Health Heroine of Health in 2022. Isata trained as a nurse, midwife, and public health specialist in the United Kingdom and worked in the National Health Service for over 25 years before branching out into global health. She joined PIH Sierra Leone in 2018 to improve maternal and neonatal outcomes and develop sustainable and scalable health programs through health system strengthening. Over the last 7 years, she has led PIH Sierra Leone through a process of massive transformation of healthcare at Koidu General Hospital, Koidu Government Hospital, excuse me, KGH, as we call it. Welcome, Isata, welcome, Sime, and with no further delay, let's jump right in. So I'm going to start by asking each of you to give us a brief overview of PIH's work. This is not just the No Woman or Girl Left Behind project, but the big picture in your respective countries. At PIH, we believe this health system strengthening work should be done within a particular model that we often describe as the 5S approach, which stands for staff, stuff, space, systems, and social support. But no two places in the world are the same, and history and local context really matter. So we'd love if you could briefly share that context with our audience. Sime, I'm going to start with you, and you have about for this. So a real summary, please.
Thank you so much, Emily, and thank you for the warm introduction. And it's an honor to be here today to talk about the work that PIH Malawi, as well as the partners, especially the Ministry of Health and other partners that we've worked with in the course of the 6 years that we've been implementing the No Woman or Girl Left Behind project through the support of the Global Affairs Canada. Very briefly, in terms of the work that we do in Malawi, we've been in Malawi for 18 years now. We started our operations in 2007 on the invitation of the Ministry of Health to work in Neno district, which is one of the smallest rural, very rural districts in the southern region of Malawi, where by that time in 2007, it was a very new district, newly formed with generally a very weak health system. It lacked so many of the fundamental elements that would make a health system function. So when we started our work in 2007, our major focus was to start building the fundamental blocks of the health system and pretty much looking around the 5 S's that you've talked about. Staffing, for instance. So really started investing in bringing in adequate numbers of healthcare providers with the relevant skills so that they were able to provide health services, and really making sure that we started pushing the quality of care that was being provided in the district. Over the years, our strategy for supporting healthcare providers has shifted from recruiting ourselves to providing resources to the ministry so they can recruit healthcare providers on their payroll, and that way we are able to address issues of sustainability. But we continue to support with training as well as mentorship so that we maintain the quality of care. We've also, over the years, been supporting with medical equipment as well as supplies. We've also been supporting with provision of actual space. As I said, the time that we were coming into the district didn't have a secondary care facility. Pretty much it did not have a hospital. As such, all critical cases were being referred out of the district. And this is a district that has no road network. The nearest hospital would be about 100 kilometers And if we have to refer a patient, a maternity case, for instance, that would mean subjecting them to really difficult and bumpy roads, especially during the rainy season. These would be very difficult circumstances to transfer our patients. So the first thing was to construct a district hospital so that we were able to contain most of the referrals and be able to manage our patients within the district. And we've continued to support the ministry with a lot of infrastructure renovations for some of the health facilities that they already had. We've constructed 2 more. From the district hospital, we've constructed a community rural hospital and another primary healthcare facility so that we are able to cover, especially those areas that completely had no facility to support those places. We continue also to support with systems, general systems strengthening. So really looking at building stronger systems that are critical for creating health programs that provide high quality care. So really looking at M&E systems, supply chain systems, even governance systems, so that we are able to have a system that is functional. So I think those are some of the things that I could highlight that we've been working on. But in terms of disease areas, we cover almost all the disease areas. So we're talking of maternal and neonatal child health, TB, HIV, as well as non-communicable diseases where we're looking at hypertension, diabetes, and even mental health. Thank you.
Great, thanks so much, Sine. And Isata, again, a quick, high-level overview about what our work looks like in Sierra Leone and the history there.
Thank you very much, Emily. So in Sierra Leone, Partners in Health came to Sierra Leone back in 2014 on the invitation of the government of Sierra Leone to support with the Ebola outbreak. At the end of which, as always, we come and we stay. So really, Ebola highlighted the poor healthcare systems that were in Sierra Leone then. And our work has been alongside with the Ministry of Health to help to strengthen that, to identify as many areas as possible where we already have expertise and knowledge in, and work alongside them to build that up. So in Freetown, we're working and supporting in the psychiatric hospital, which is the only one in the entire country. So building up with terms of teaching, training, as well as resources, drugs, etc. We're also working at the TB and HIV hospital, which is LACAR. So those are the 2 main tertiary hospitals in Freetown that we support. Again, with the same things, have minimal staff there, but really helping to strengthen and support the governments there with training and with resources. Kono, which is our main base for clinical services, we work in the Koidu Government Hospital. So across all sectors, from neonatal all the way through to adults end-of-life care. And a big sandwich of that which is where the No Woman or Girl Left Behind project comes into, within our reproductive and maternal and neonatal health care. So supporting with training, with building up the confidence, with providing the resources, providing decent spaces where quality healthcare can be given, where staff can also come in and be trained. We also have a very great community health workers program, which has been instrumental in ensuring that we can reach people from the furthest miles, both for support with HIV and TB, as well as with traditional birth attendants, building up the model of accompaniment, which is what PIH is known for, where we started from, accompanying patients to the last mile to access healthcare. As a result of our work there, the government of Sierra Leone and the World Bank looked at what we do within our primary healthcare units and asked PIH to extend to 6 other districts within the country to support, to build up and copy the same sort of 5 S's model to build up hubs and spokes. So you have a central place and then smaller units that feed into there and ensure that you can get healthcare, not just in main hospitals, but in primary healthcare units as well. So that is the sum of what we're doing in Partners in Health in Sierra Leone. Thank you.
Great. Thank you so much, Isata. And I'm going to go right back to you, Isata, for our next question. So Isata, you just joined PIH Sierra Leone right around when this project started. And I'm wondering if you could briefly describe what the landscape was like for sexual and reproductive health and maternal health in like what you saw arriving. And then I know this is asking a lot, but just give kind of a big picture, some big picture thoughts on the transformation that has taken place over the last 6 years and the role that the No Woman or Girl Left Behind project has played in that.
Okay, so I came from a very protected, westernized background of delivering healthcare in the UK, and coming to Sierra Leone, it was shocking what I saw in the maternity unit, for instance. The number of staff to patients ratio was about one staff expecting to look after 8 or 9 pregnant women in antenatal or various stages of labor or postnatal care all at the same time. The maternal mortality rate was quite high back then, not just in Kono, but all over in Sierra Leone. In the first year, in the first 6 months, I arrived there on the 1st of July. And by the end of 2018, we'd had 35 maternal deaths. And it was really shocking, not just the number, but also the reasons why they were dying and the level of acceptance, both from the patient side as well as from the staff side, that there's nothing we can do and she's going to die. Forward on to where we are now because of the results of the program. So the program itself really helped in terms of one, the staffing, increasing on the number of staff that you need to be able to adequately care for people, women in along the reproductive health cycle, and not just in the numbers, but also in the training, providing them with adequate training so that they are able to recognize and also able to act on with the resources that are there, which wasn't there as they should have been in the first place, really being able to use those resources to help to save women's life. Being able to provide services such as safe blood transfusion, being able to go out and do blood drives within the community to ensure that when a woman comes in who is bleeding and needs blood, which is, you cannot buy this, but you need to have it in stock to be able to save a woman's life, being able to produce and provide that as a result of the program really started to change how and what was happening with our women. One of the biggest transformations was seeing the change in the staff themselves. Going from, I'm sorry, there's nothing I can do, she's going to die or she's dead, to now really actively saying she must not die because we have everything that we need to put in place to ensure that both the mother and her baby leave here well, alive, and in a good condition. Working also, moving away from, once we had got those systems in place, thinking more about preventative care, really working in the communities as well, and targeting especially adolescents and youth, because we had a high turnover of those 35 women that died. A lot of them were young women under the age of 18. So high teenage pregnancy rates, unwanted pregnancies, unsafe abortions, all of these things were really adding up to the poor outcomes. So really working alongside with the Ministry of Health and saying, let's go into schools. Let's start doing an adolescents and youth-friendly program that talks to young people about sexual and reproductive health rights, strengthens them, provides them with the services that they need, so you don't have them coming to you in these conditions in the first place, as well as providing a safe space and a youth-friendly space that they feel comfortable about coming to, so that they can explore and access these services. Working as well with our traditional birth attendants. So we had a lot of home deliveries. And home deliveries because mothers were scared to come into hospitals, because you come into hospital and you're going to die. And you come into hospital and services are not available. There are no personnel available, and it's not, the space itself is not inviting. Changing all of that around to make it a place that you would want to come into, but also now working with the traditional birth attendants to encourage them to say, please, do not do home deliveries, do not care for these women at home. Accompany them to a health center where they can receive care from trained providers. And if at all needed, we can then move them from there onto the hospital where they can get emergency cesarean sections if needed. And this has helped to change the landscape of how people view maternal health in our district, and not just in our district, as a result of building these up, we have now become one of the premier hospitals in the country where from the national side and all over, people refer, self-referrals as well as hospital referrals to say, go to Koidu Government Hospital and you will be able to get the quality and standard care that you need. So that has been the overall turnaround and life-changing things that have happened as a result of this project.
Amazing,
Thank you.
Isata. And I happen to have our data and reporting documents up because some of Isata and Sime's colleagues and I are just finishing a GAC on this. So just for like a cold hard number, in the first year of the project, there were 18 maternal deaths at KGH from direct causes. In the 5th year of the project, which is last year we have full year data for, it was 4. And that's despite in that time the number of deliveries at the hospital went up by 45%. So they're handling more and more patients and yet fewer complications because they manage them in advance, way fewer stillbirths as well, and way fewer maternal deaths. So really just, it's there in the numbers, the incredible impact this is having. Really exciting stuff. Okay, Sime, over to you a little bit about the big picture impact of the project over the last 6 years. And I want to mention this project had different areas of focus in different sites. So in Sierra Leone, more resources dedicated towards transforming maternal health. And in Malawi, a lot of the resources were more at a community level with maternal health aspects, but also a lot on work with adolescents and around gender-based violence. So different kinds of highlights coming out of Malawi. Go ahead, Sime.
Thank you so much, Amy, and really interesting to hear the impact that is coming from Sierra Leone. Yes, in terms of the burden of maternal health issues might be slightly different, but through implementation of this project, we've also seen quite significant improvements, even in our own maternal mortality ratio here in Neno. Because I recall when we were starting in 2019, we were registering just as Neno district 79 deaths per 100,000. But we've managed to push that number to 58 as of 2024, which is a huge improvement, especially when we look at where we started, especially like around 2007 and all that. So really huge milestones to which the No Woman or Girl Left Behind project has managed to contribute to. But speaking to components related to adolescents, I would say one of the major milestones that we've also seen is that increased knowledge and awareness around sexual and reproductive health issues, and most importantly, on sexual and gender-based violence. Isata talked about the level of acceptance when women die, where service providers say there's nothing that we can do, and even community members equally echo those sentiments because of how where they've been subjected. It was a similar thing here in Malawi, where you would see an adolescent girl or boy wanting to access sexual and reproductive health services, and they would go to the facility, and it would not be strange for this adolescent or the youth to be turned back and not access the services, because everybody felt, yeah, I mean, why would you be accessing sexual and reproductive health services if you're not married and you are young, or maybe you are in school? So it's something that was socially accepted and not really perceived as a right to this youth, to this adolescent, that they do have this right to access care and services. Even worse would be issues surrounding sexual and gender-based violence, and especially Malawi being a very conservative country. We used to see a lot of cases not being addressed. So some of the successes that we've seen through the establishment of what we called the virtual one-stop center. So this is a center where sexual and gender-based violence cases would be managed across a number of functions. Ideally, when you have a one-stop center, you have an infrastructure that houses all these services so that they are easily accessible to the survivors. But we did not have the resources to have the physical infrastructure. But we nonetheless knew and understood that the communities desperately needed the one-stop center services. So what we ended up doing with our stakeholders, we decided we could still do this as long as we set up very strong and very clear referral mechanisms amongst ourselves. And with the support of technology, being able to communicate through calls or WhatsApp, we managed to start this one-stop center and started providing services and being able to link the survivors from one service provider, sending them, maybe they would come from the health service providers, go to the police to provide a statement, go to all the way to the judicial stakeholders, and really see them all the way up to the community who is supporting them, who is protecting them in case they can't go back home. So really linking all the key stakeholders, even though we did not have a physical infrastructure. So we saw tremendous improvements in case management and follow-up through this structure, so much that we started getting recognized as a center of excellence. In this particular regard, that would be a center of virtual excellence. And other districts were now coming to Neno to learn about our model and how they could replicate it into their districts. Because we became efficient at managing and following up on SGBV, sexual and gender-based violence cases, we gained confidence of the community. And gradually we started seeing the community coming out to report the cases, which was not the case in the past. And one example of how strong this system became was an incident that just happened last year, where we had one police officer who was arrested because he was having sexual affairs with a minor. This, in the past, would have been covered up, would have been pushed down under the carpet, and practically this person would have been shielded by his colleagues. But he was taken to task by his own colleagues who brought him to book. And this person is still on remand as we speak. And his case is expected to go to court on 20th February. So this is one for us in a context like Neno, the context like Malawi, where it was unheard of, and especially for people of higher ranks or people that are connected in the society. Such injustices would never have been addressed if we did not have a platform where we started talking to communities and really addressing these issues to say, these are wrongs that needs to be addressed. And then we put the system in place so that people knew to say, if it happens, this is where I go to get support at community level. And this is where I go to get a health facility related services, police related services, and even judicial related services. So I could highlight that as one of the major milestones that we've seen coming to light through this project.
Great, thank you so much, Sime. And I think you made a really important point about the trust that is earned from a community. You know, I mean, at a time when if someone came forward as a survivor of gender-based violence or of sexual violence, if there were no services for them, if they couldn't trust that their case would be handled sensitively, if they couldn't trust that they would get care, you know, then there just is no trust. So the difference that it makes by providing those services and proving to a community that we, you know, that we will have that follow through, I think is really important. So actually, kind of I'm going to come back to you, Sime, with another question that kind of expands on this topic and about the incredible work that APSU has done during the violence, which is one of the benefits of the model of PIH, is that we work very closely in locations with colleagues at the Ministry of Health, and because that we usually work quite intensely in limited geographic areas. In this case, largely in Kono district and in Neno district. But we are able to affect change beyond that geographic scope and at a more national level through, we like to say, proving what's possible at the local level and then participating in national level dialogues around these issues. So Sime, some of Malawi's work around gender-based violence, which originated in this small district of 135 people, Neno district, has really had a national policy impact in this country of 20 million. So could you talk about one or two of those big successes and kind of what that story is about how what we essentially piloted under the No Woman or Girl Left Behind project has had that national impact?
So the challenges of not really having systems was not a challenge that was unique to Neno. This was a challenge across the country, so much that there was very little that was being done at national level. Of course, there would be other targeted projects that were probably tracking indicators at project level, but really talking about national level, we did not have section gender-based violence tools, as well as indicators, national indicators. So when we started this work in 2019, that was one of the biggest areas that we started looking into to say, what do we track and how can we create data that can also help us to demonstrate the scope of this problem at district level, at national level, because if you don't have data, then the issue really doesn't exist. And it becomes very difficult for you to advocate for resources, for policies, for anything if you do not have meaningful data. So we started working and through the project, we developed data collection tools, which eventually were adopted at national level. And the central ministry came and adopted and used what we had, the tools that we had, the referral system that we had instituted in the district, the data collection tools, they came and picked this as the blueprint that was now used at central ministry level for developing harmonized data collection tools. And then which led to now, as a country, we have a national SGBV register. Through the same project, we also contributed to the review of national level SGBV indicators and supported their configuration into the district health information system, which is the national level data collection system. So as we speak, at national level, we do have data collection tools. We've got a national register, which has been decentralized to all districts, that they are able to track and monitor what is happening in their districts as it relates to sexual and gender-based violence. And we've got specific indicators that we are reporting to as a country, which was a huge boost to our team, because there's a saying here locally that nothing good comes out of Neno, but because it's a very impoverished district, and really people didn't have much expectations. But when we started exporting these very critical instruments to the national level, we started really attracting the attention of critical stakeholders. We've also contributed to the development and review of national level policies, different policies and guidelines at national level, including the national guidelines on management of rape and SGBV survivors. We've also contributed, we're a critical partner to the formulation of the national SGBV male engagement strategy. So we are quite hopeful that these are instruments, these are policies that are going way beyond the district, but even way beyond the time frame of the program.
Absolutely. Thank you so much, Sime. And just, I think the story of that register and of just getting information, getting data is so powerful. In the first year of the project, I had the good fortune to spend some time in Neno in early 2020, just before the pandemic, like immediately before. And some of Sime's colleagues showed me the new SGBV register, and we're talking like a book, like a big book like this, a big paper register that they had printed out. They printed 14 of them, and they were going to deliver one to each health center around the district. They were training health staff how to use this thing, and this was how it started, right? The fact that that 5 years on, we're seeing a system like this adopted nationally. We're getting digital data at a national level about these kinds of indicators, about information that's just not present before, is really amazing. Okay, I want to give the floor back to Isata, and Isata, I'm wondering if you can talk a little bit about how we and you have been engaging at a national level in Sierra Leone around issues of maternal health, adolescent health, sexual and reproductive health, and what kind of impact and engagement we're able to have in Sierra Leone at that national level.
Thank you very much. So there's just so much. I don't even know if I can unpackage it all in the time that we have left. But firstly, on a national level, as a result of all the systems, all the training, all the resources, all the staff that we have in place, our hospital, Koidu Government Hospital, has become, like I said earlier, like a national referral center, not just for maternal and reproductive health rights, but generally on the surgical side. You have people, we should be referring, because Koidu is a small districts hospital with just over 600,000 people. So we should be referring up to our regional hospitals and then to the tertiary level. But as a result of the care and the standards that we can give, it's going the other way. Starting off with the gynae clinic. So there is nothing like that you will not find in a government hospital in Sierra Leone. You to access gynecological and reproductive health services, you'll have to pay for that privately. So we currently have that. What we started off with 20 people in a month has now become a clinic that is seeing over 600 people every month. And we are thinking about having to extend that. The other big thing that we've done that has really had an impact on the national program and has helped them to redesign how they offer care in that particular area is with cervical cancer screening and treatment. So this was something that was new and came in at a very late stage at the end of 2023 of the program. Now, Kono is a mining area, and therefore you have women and young girls exposed to sexual activity at a very young age. And we also, up until, again, in 2022 was when they started doing vaccinations for HPV, human papillomavirus, which prevents the spread of cervical cancer in women. And they were only doing that for children aged 10 years. So we immediately stepped in and helped to support with that to ensure that across our district and the neighboring districts, we were able to support with the transportation, as well as how do you escalate this to more girls that are maybe between 10, 12, etc., and helps them to write up the program about that, as well as how can you access continuous funding so that this was not going to be a one-off experiment, but something that now has become a national integrated program to say that all young girls from 10 and above are now going to be vaccinated. But also for those that are not, and those that are aged from 25 and above can now access screening for cervical cancer. This is a totally new thing, and our center is taking the lead on that because we also happen to be one of the few sites that have the obstetric and gynecologists that can not just offer and do the screening that the nurses can do, but also take it right down to the very last end of treatments that any woman who is positive will be able to access care for. So we've gone from not being part of that national program at all, because you are a small district hospital, to now being the lead that supports the government to how can we extend and expand on our cervical cancer program, and how can we ensure that we're able to reach as many women as possible, not just within our districts, but beyond. And for those that need more than the nursing care, the initial treatments, please send them so that we can be able to offer them the service that are needed. And then with our adolescents and youth-friendly program. So we, again, started off just on the back of COVID in 2020. It was a small room. It has now become the blueprint of how to offer adolescents and youth-friendly services, not just in schools. So we have a school program that the National Secretariat for Teenage Pregnancies has adopted as part of their curriculum and deliverance in all districts, that you go out and form school clubs. And this is the way to go about doing it. So we integrate with them, they come and do the training, and our trainers also help to go and set up these school clubs as well as peer support groups that then, even if you don't have an adult person or the adult person there is only as an observer, the young people are able to educate, engage with their colleagues on sexual and reproductive rights. And this has become something that has now been adopted as a national program for all across the districts that try and open up school programs, peer support groups, as well as clinics that are geared specifically for adolescents and youth. Clinics that also attend to sexual transmitted infections, as well as minor ailments, and for those that are pregnant, that will be able to offer focused antenatal care for young people. So these models, when somebody says, I want to open up an adolescents and youth-friendly service, you are then referred to Connor. This is the model, this is what they use, this is how you go step by step. You might not be able to adopt all of it because of funding constraints or space constraints, whatever. What do you need to focus on within your area? And this is the best way to go about adopting it for you to get the best results for young people. Thank you.
Amazing. Some really great examples there of the PIH proving what's possible approach. So Before we open it up to questions from the group, and I'll invite participants, please feel free now if you have any questions to send them in the chat, and we'll be vetting them and passing them along to our panelists in a couple minutes. But just before we do that, a question that we often get from all kinds of people, including our major donors, is how can we keep this work going now that the project is over, this particular package of funding is over that we've had from Global Affairs Canada. So because the PH model is to stay and to make these long-term open-ended commitments to the countries where we serve, we don't have an exit strategy. We don't plan to close down. So let's talk a little bit about kind of what's next at both sites, about how we keep moving forward. Now, Isata, some people here will know about the Maternal Center of Excellence, which is going to build on some of the successes of No Woman Girl Left Behind, and which is in the late stages of construction now with a majority female construction site workforce, which is so cool. So maybe you'd like to tell us a little bit about that, and then we'll turn to you, Sime.
Thank you. So as you said, PIH is here to stay, and healthcare is not about sustainability. People don't stop accessing healthcare just because a project ends. They don't know that a project is ended. I'm still going to be sick, and I'm still going to want to have access to the same quality and standard of care that I was given when the project was running. So there is no sort of we stop and now we go back down the slide again and we wait for another project and pick ourselves up. So we have been thinking about this over time, and the No Woman or Girl Left Behind project has been a great platform to help us to raise our standards and to put systems in place to offer quality maternal health care. The Maternal Center of Excellence will be a continuation of that. So that is 120 inpatient bedded hospital that, as you say, is in the late stage of construction. The only building that is left to do is the outpatients department, which would be for all antenatal clinic, postnatal follow-up care, family planning, adolescents, and cervical cancer, etc. So the Maternal Center of Excellence is going to be a site within Koidu Government Hospital as part of the hospital within the same campus that is really going to change the way that we deliver healthcare within Sierra Leone. So it's in Kono, but it is for the nation. Already we've started working on improving the training that is offered to all the staff that are going there, ensuring that people go and get upgraded so they come back. Instead of having certificate level nurses, you have diploma level nurses and BSc level nurses, working with the doctors to ensure that what they are reading and seeing in theory or seeing on a video, no. You can come to the Maternal Center of Excellence and have the space as well as the resources and everything else that you need to be able to put this into practice. So purpose-built to ensure that women in Sierra Leone can have access to the same level and standard of care that I would expect in the UK, in the US and Canada, wherever it is I go within the developed world. I am entitled and I should have that there in Sierra Leone. So ensuring that that is there, but not just in the space itself, but in all the steps that are needed to ensure that once you are in there, you are able to get the highest quality and standard of care. And a space for our healthcare professionals in Sierra Leone where they can train and also train others so that we don't always have to be sending our healthcare professionals outside of Sierra Leone to get high quality training. It would be available within there. And it's such a dream, and knowing already that we are already winning, we are having people refer themselves as well as be referred to us. So the end of the project means that we've got the baseline and now we can continue growing on that. Yes, we will still need the resources to be able to do that, but we know that we've got the space, we've got the resources, and we've got the initial things ready, and we're good to go. And so looking forward to having the Maternal Center of Excellence opened and be able to deliver all these impactful services that we've started already.
Amazing. Thank you, Isata. And Sime, how about for APSU? What does the future look like?
Yes. So for us, because most of the interventions that we were focusing on were tackling two main pillars. So we had the community pillar, where we were strengthening gender sensitive, as well as infusing rights-based approaches to our screening programs and services at community level. So, and then at the facility as well, really seeing how we could build in youth-friendly services and gender-sensitive as well as rights-based approaches into our screening programs, but also generally building the capacity of our service providers, both at facility level and at community level, in terms of how they can provide services that are adolescent, youth-friendly, but also really serving the specific needs of women and girls. So there are components of the program which from the very beginning, we already started integrating them into our existing programming. And we were actually like building on top of the already existing programs, the already existing approaches that we have in the district. So for those, we are confident we should be able to continue leveraging on the unrestricted resources that we have as an organization, but also the existing programs that we are running as an organization. But there are certain components of the program that will have to be transitioned, some to the Ministry of Health, some to the Ministry of Youth. For example, the youth corners and the youth-friendly health services. These will be transitioned to the ministry so that the ministry can incorporate them into their existing programs. And we've been working with them for quite some time now to say, how do we, when we get to this point, how can we achieve that seamless transition so that we don't destabilize the services and the systems that we have put in place. But like any other project, any other grant, there will still be some elements that would still require additional resources, because probably these are areas that we came with the grant and were very new to the grant. I would give an example where through the program we were supporting court circuits. So these are like community-based court circuits. Our judiciary, district level judiciary structures, they don't usually receive adequate funding. So you would see that there would be cases that needs addressing, but because of lack of funding, those cases would store for quite a very long time. So there are those mechanisms where they're able to go at community level and hold these sessions so that they're able to expedite the hearings. So those are some of the things that we used to support so that we are able to within that process, able to also address some of the issues or the cases that were related to our program. So very specific interventions like those would definitely be the activities that would need ongoing support. So these are the challenges of grant-based projects that we have come to accept. But as I've said, to a very large extent, we are quite aware that we have to work with the existing structures, with the government structures and stakeholders, so that when a time like this comes, we do not find it very difficult to transition. And it's an approach that we have found to be quite useful. So we are hopeful for those that, for those very few components that would still require ongoing resources, we'll continue with fundraising and resource mobilization drive to make sure that we can find resources to cover them. But a good number of them, we've managed to integrate them into our existing PIH programs, as well as existing MOH and other stakeholder structures. Yeah.
Thank you so much for that, CMA. And as there is a representative PIH Canada, which is a fundraising office primarily, I mean, of course, we, together with our colleagues in the US, hold a lot of that responsibility for resourcing this work. You know, we're incredibly lucky to have individual donors who have funded a lot of this work, and who, you know, we could rely on, many of them long term, you know, sometimes at you know, small donations over time that really make a huge difference in terms of sustainability. We're always working on more grant applications. Yeah, I mean, this is what I see as, you know, as part of my role, and something, a role I'm very proud to play, is helping to resource this incredible work that Isata and CMA and their colleagues are doing. So we do have a couple of questions from the floor. One question that I think I'm going to pose to Isata was a question about, there was a question about, they asked, is PIH involved in pediatric care and in teaching pediatric care to nurses so they can educate mothers in care of infants and children? So I think an element there about, you know, about maternal education, about that continuum from maternal care to neonatal care to, you know, children going home, and whether, you know, what support families have in caring for and learning about how to care for their children. So thoughts on that, Isata?
Yeah, so the answer to that is yes. We're involved in all aspects of pediatric care. Breastfeeding is one of the key things that we encourage, breastfeeding right from the first hour of birth. And we have our nurses all fully trained in that, and how to monitor the growth and development of a baby. We have postnatal clinics, so we see all our new moms up to 6 weeks post-delivery, and they continue to access care within the community health services. And we also have a very, very good pediatric department with pediatricians, neonatologists, etc., heading and looking after sick children through there. But also a good component of our work is trained on well babies and how to ensure that children access immunizations. Children are growing and thriving as they should do, attend well baby clinics, and our traditional birth attendants are really supporting with that as well in the communities, ensuring that they keep on doing home visits, as well as accompanying the mothers to the clinics as and when needed.
That's great, Isata. And we actually had another question just asking for a clarification on the traditional birth attendant initiative, how it is that we've been working with traditional birth attendants within this project, and kind of what their role can be and how they could be integrated into systems. So do you want to maybe just give a kind of an outline of what that initiative has been and how it's worked?
Traditional birth attendants have always been in the system and within healthcare, whether they're recognized or doing it undercover. They're always there. Women trust them. They're in the community. They have because of the way how the Sierra Leonean healthcare system had been eroded during the Civil War and all the way through to Ebola. So that's almost 25 years of no trust in the healthcare system. Women would go to the traditional birth attendants. Our way of working with them is to have them integrated into the healthcare system as accompagnators, as people whom, yes, you are trusted. Yes, a woman would come to you, but please do not do any sort of thing that remotely looks like healthcare practices. Stop all the herbs, stop all the massage, everything. Just stop. Accompany her, but educate her on what to expect as danger signs, to recognize those, when to access healthcare. When you are pregnant, rather than waiting till you're 6 months pregnant, please come and I'll take you to the healthcare center from your first trimester, so you start accessing healthcare services right through from then, and be with you all the way through during delivery, accompanying a social doulas in the form of comforting, in the form of reassuring and ensuring that they have a birth companion support if the partner or anybody else cannot be there. And when you go home, accompanying and ensuring that the baby itself is being well cared for from somebody who has that experience, but not necessarily the healthcare background, and supporting them always. First access is a healthcare professional.
That's great. And, I think we also recognized that, these are roles that women in our communities have been relying on for their income as well. And so part of the model that this project has worked on and that PH Sierra Leone has done has involved compensating traditional birth attendants, and actually in a system where they're compensated according to the number of referrals. I have to say, from what I've learned from Isata and her colleagues, there's no better sort of spy within a rural community in terms of knowing who's pregnant and who might need to go to an ANC appointment than a traditional birth attendant. She knows.
She knows. Just one look, like.
Yeah, and the data in terms of the that I'm seeing in the reports about the the rates of antenatal care appointments and so on, just going up and up and up. Women getting to the hospital on time because our traditional birth attendants are working alongside us in this amazing way. It's been great. Okay, I'm going to pose a question. Sime. So this is relevant to both sites, but I'll let Sime take this one. During this project, we've done quite a lot of work with adolescents on teaching them about issues like sexual and reproductive health, gender-based violence, rights and consent, and ensuring that they're empowered to make decisions for their own bodies and health. And this, under this project in Malawi, there was a very cool component of the project that was the skills program that we delivered in partnership with an organization called Grassroots Soccer that was working with groups of 10 to 14-year-olds in clubs for like a 17-week curriculum that was a very fun and play-based way to learn about rights and health. But dealing with major topics around gender dynamics and around consent and about learning about comprehensive sexual and reproductive health. Now, some of these can be controversial or sensitive topics. You talked about a conservative environment, Sime. So have you seen pushback from the community as we've done this work at all? And if so, how is that being addressed?
Thank you so much. Obviously, if you are talking about sexual and reproductive health and you are talking to 10-year-old boys and girls, I think generally it's a concept or thought that would worry any parent. So yes, this is an area where many communities, many parents are quite jittery about it, not just here in Neno, I would say even at national level. But I think the two ways that we addressed this. First of all would be the question, why in the first place target a 10-year-old to a 14-year-old with sexual and reproductive health information? So at the very beginning of the program, when we were grappling with how do we address the issue of knowledge gap, and who do we address to be most effective? And we came to the conclusion that it would be best to start with these younger ones. The reason being, there's a saying that train a child the way that they should go, and when they are old, they will not depart from it. So pretty much giving these young ones information before they need it. So really investing in providing accurate and structured information, and really, first of all, helping them to understand critical information about sexual education, that this is a responsibility that they need to take care of because it's directly linked to their health and the quality of life. So really supporting them with the right information at the right time, so that when they are growing and get to a point where they would need this information, they have it handy, because you never know at what point this child, this boy, this girl will become sexually active. But you also don't know at what point, unfortunately, this child will meet a misfortune where they are molested, or they are defiled. So you need them to have information in good time, so that they're able to use that information when it's needed. So obviously, at the very beginning, the concern was, you talk to children about sexual and reproductive health, you are telling them to start having sex. So the way we countered that is, like many important things in life, we go to school to gain knowledge that we are not going to use at that particular time. This is knowledge and skills that we are collecting so that we can become productive citizens at a later stage. So really trying to work with parents through community health workers, and really building in that element of community education to say, information is power, and especially if we give the right information at the right time. These adolescents, they need to understand their sexual and reproductive health rights. They need to understand what their role and responsibilities are, but also where they can access these services, and what and the type of services that they should expect to receive from different places where they go to. So it was a journey, but we worked and walked together with the community. As you've talked about, it was quite a comprehensive training program with a 17-week curriculum. And by the time that we were developing, we engaged ministry or government stakeholders, relevant government stakeholders, to make sure that the information, the data was relevant, was culturally appropriate. So we did not disregard the cultural issues, but worked around how we could use those cultural elements to strengthen the point and the information that we were trying to provide to the adolescents. So really working with the community, working with the youth themselves, working with various government stakeholders to come up with the right content and deliver it in a culturally acceptable, but even fun, because these are 10 to 14 year olds. So yeah. I think that's what I could say.
Thank you so much, Sine. Now, and we're 10 minutes past time, so we're going to wrap up in the next couple of minutes. I'm going to ask one very short question to Isata that just came in through the chat, which is just someone wanted to know if we have a tentative date for opening of the Maternal Center of Excellence at KGH. So do you want to share that? And then we will wrap up.
That's a secret. And you're all welcome to attend that. So the plan at the moment is that by the last quarter of this year, we would have the inauguration, because everyone is so anxious and looking forward to having this Maternal Center of Excellence open. We haven't got an exact date yet, but we know that this will be done before the end of the year, and hoping to start delivering services within there shortly after, or as soon as we possibly can. So we're nearly done. They still have the outpatients department to complete, and that is not due for full completion until late 2026. But the other buildings that have the birthing center, the theaters, the neonatal intensive care units, the critical care unit, post-operative ward, and the antenatal and postnatal units should be ready for inauguration in the last quarter of this year.
That's great. And the Maternal Center of Excellence, the campaign for it has been supported very significantly by a lot of individual donors, as well as our major donors, the Green Brothers. So I imagine some of the people who helped make that possible are participating on this call, which is great. Really, it's been a wonderful, wonderful thing. And we're so excited to see it running. Okay, so we're going to move to wrap this up. Just before I do, I wanted to ask my colleague Connor to drop a link in the chat for another webinar that PIH, like the American entity of PIH, our partner organization, is hosting tomorrow about the impact of changes, cuts, elimination to USAID right now, and about just what's happening globally following the United States positioning on aid, as we talk about fundraising and the global aid ecosystem and, resources for this. I think that's a really important topic. So Connor will drop that in the chat. Thank you. And with that, I'm going to move to wrap up. So thank you all so much for coming. We really hope that you'll stay in touch with us by signing up for our newsletter and look at some other information about us at pihcanada.org. And if you have any, or you just want to send us a note, please reach out to us at pihcanada@pih.org, and we'll get right back to you. I'll get one of my colleagues to drop that email address in the chat too. Happy International Development Week. A huge thank you again to Sime and Isata. This has been just wonderful and so inspiring. And we'll see you all soon. Take care, everyone.
Thank you so
Emily.
much.
Thank you, everyone.
Okay.
Goodbye.
Okay.
Thank you.